Hey everyone, welcome to the Acute Stroke Management lecture of Neurology for the Non-Neurologist. As a non-neurologist, it's unlikely that you'll ever be tasked with making the decision to give or not give TPA in an acute stroke setting, but it's really important that all physicians know the process involved in these situations so they can really help expedite patient care. Remember folks, time is brain, so let's dive into it. So here's my usual disclaimer. Remember, Neurology for the Non-Neurologist is built to help you succeed on neurology rotations. It's not an all-encompassing review of the entirety of neurology. So this lecture is broken down into a couple of components. First of all, we'll talk about the initial evaluation of stroke, including history, exam, and imaging. Then we'll touch on the use of TPA and thrombectomy for intervention, before finishing with immediate post-stroke management. I won't be discussing stroke etiologies and workup, as those have their own lecture series. Okay, so let's get started. The first part of evaluating a possible acute stroke, before you even examine the patient, is to understand the history. If there's only one question that you can obtain during history taking, make sure that you know the time of last known normal. Timing is critical in stroke, as intervention only has a limited window of efficacy. If a patient had acute onset weakness 1 week ago, they still deserve a neurologic workup, but please don't call a code stroke. However, a patient with acute neurologic changes within the last few hours needs emergent attention. Timing is key here. Another important thing to consider in history is the acuity of symptoms. Remember, stroke symptoms should come on immediately, and we'll talk about how this helps us rule out a couple of mimickers in a second. If you have time, you should also attempt to determine any pertinent history that may be a contraindication to TPA, including anticoagulation use, which I'll touch on in a second. Associated symptoms and pertinent medical history are also important here, as they help us rule out mimickers, but don't waste a ton of time gathering these. Quickly, let's touch on some of the stroke mimickers, as there are several of these that you should be aware of. By far, one of the most common and easily correctable conditions associated with sudden onset neurologic symptoms is hypo or hyperglycemia. If a nurse calls you with a patient who has new onset neurologic symptoms, you should be asking her to check a glucose before you've even reached the room. In fact, a glucose below 50 or above 400 is an absolute contraindication to TPA unless corrected. Seizures with prolonged paralysis is known as Todd's paralysis and can often be confused for stroke. In these patients, history is key, as you want to determine if they first had a seizure and were later hemiplegic, or if they had a stroke and then developed seizures as a result of cortical irritation from stroke. This is usually a tough call, and so these patients often get TPA. Another set of diseases you should be aware of are meningitis and encephalitis, as they can appear similar to stroke, though these often have a more indolent course and are associated with fever. And then, speaking of fever, always keep endocarditis on your differential for stroke. It's important to rule out endocarditis because it's the only type of ischemic stroke that we will not give TPA to, and this is because septic emboli have a really high propensity to bleed and can cause rapid decline. Let's keep going with a few more mimickers. It's rare but not unheard of for complicated migraines to cause hemiplegia, and this can actually be very difficult to differentiate from acute stroke. While certain things can clue you into a migraine like history, young age, and of course a headache, the most important way to differentiate the two is by neuroanatomic spreading of symptoms. What I mean by this is that in migraine, symptoms will somewhat slowly track up or down in the body, and by slowly I mean over the course of seconds to minutes, but this still isn't as rapid as a stroke. The reason this happens is that migraines exhibit something called cortical spreading, which is a phenomenon where the disease moves slowly along the cortex. So if you think about it, you can imagine the migraine marching down the motor homunculus, and the person losing strength in their hand, then their arm, then their shoulder, then their face. It's actually pretty interesting. That said, it's really difficult to differentiate between complicated migraine and acute stroke, much like in a Todd's paralysis, and so these patients often are going to get TPA as well, especially given that they're usually young, healthy patients with a lot to lose. And then finally, you need to look for stroke mimickers that can be seen on imaging. As we discussed, this is why we get a non-con head CT and why it's imperative to the acute stroke workup. Either structural lesions such as neoplasm or abscesses, or hemorrhagic strokes and bleeds must be ruled out before giving TPA, as they can have catastrophic results. The next step in acute stroke care, as with much in neurology, is a good exam. Now, this doesn't mean you're going to go start testing vibratory sense in all your patient's toes during an acute stroke, and that's why we invented the NIH stroke scale, really to focus your exam. The NIH stroke scale is a standardized means of evaluating a stroke patient. This means that all components of the test should be performed exactly the same every time. By doing this, the exam becomes as close to an objective measure of stroke symptoms as one can obtain. Of course, there will always be some subjectivity in scoring, especially when symptoms overlap, but the scale in general allows for one to appreciate an overarching severity of stroke. I included the stroke scale here on the right, which is probably pretty much impossible to read, but it consists of 11 steps, each of which score on a scale anywhere from 0 to 4. These add up to a total score, which allows you to determine severity of stroke as seen here, with minor strokes being in the single digits and severe strokes being 20 plus. If you want to learn how to actually perform the stroke scale, we'll talk about it in the physical exam videos, but in the meantime, you should at least be familiar with the concept and general severity levels. One thing I do want to touch on is that something we call anterior circulation strokes, and specifically ones of the left MCA, are heavily favored by the NIH stroke scale. This is because we highly score things like aphasia, facial droop, and weakness, all of which are symptoms of a left MCA stroke. Part of this is by design, as left MCA strokes tend to be one of the most debilitating strokes we have, but it's really important to be aware that posterior circulation strokes, including the deadly basilar stroke, may not trigger a very high stroke scale. So using the stroke scale, so it's important to use the stroke scale, but don't turn a blind eye towards other symptoms that would clearly be considered debilitating. I think a couple of important examples of this that are not tested by the NIH stroke scale are the ability to walk and hand strength. I've seen patients score a 0 on the stroke scale when their only deficit is complete hand weakness. However, this is clearly a debilitating symptom, especially if they're, say, a carpenter or musician or surgeon. Likewise, a patient may score really well on a stroke scale, but they might be completely unable to stand, say if they have cerebellar deficits. So considering TPA in these patients is really important, even if their stroke scale is minimal. Another helpful clinical pearl to understand stroke patients is the concept of gaze deviation. So gaze deviation is a really important concept in neurology because it grants you a lot of insight into the function of the frontal lobe. This is because the frontal eye field, which I'll circle here, frontal eye field sits right in the frontal lobe, and it functions to push the eyes to the opposite side. So the right frontal eye field pushes the eyes to the left and vice versa. So this means if you have a stroke in this area that knocks out one of these, the eyes will be pushed in the direction towards the stroke. Versus on the contrary, if you have stimulation of a frontal eye field, say if you have a seizure, it's going to become hyperactive and it's going to push the eyes in the opposite direction. This is really important because it helps you understand the phrase, look towards the stroke, look away from the seizure. Understanding this is really helpful in helping you differentiate between seizure and between stroke and then, like I said, seizure with Todd's paralysis, which can often be very difficult. Finally, a key component to any neurologic exam is ruling out functional syndromes. A key to this is looking for symptoms that don't localize well or ones that are intermittent or distractible. With enough practice, you should be able to recognize patterns of common stroke syndromes, and when you're not really localizing a pattern, it's probably because there isn't one there. That said, be very, very careful with this, as brainstem strokes have what we call cross syndrome or cross symptoms, say symptoms on the right and left, and they can be really difficult to localize. But writing off a brainstem stroke as functional can be a fatal mistake, so just be really attentive with your exam. One test you'll see a lot of neurologists perform when we're questioning a functional exam is the drop arm test. So in this test, you take the patient's weak arm and you hold it above their head and you drop it. The functional patient will pretty much always veer away from their head, while the truly weak person will smack themselves in the face. It sounds pretty cruel, but if you can prevent a functional patient from receiving TPA and the risks associated with that, it's absolutely worth it. So great, you've gathered a history and you performed a stroke scale, but what about the rest of your staff? In a code stroke, it's important to have ancillary staff gathering quick data for you. The two absolutely necessary data points you need during a code stroke are glucose level and vital signs. Again, hypo and hyperglycemia are common stroke mimickers and are also contraindications to giving TPA. And then within vital signs, especially blood pressure is important. This is because hypotension can mimic a stroke and severe hypertension is another contraindication to TPA. Temperature is of course also important. As I said, it will clue you into things like meningitis or endocarditis. Another lab that ideally you obtain during a code stroke is a creatinine. As we'll discuss, vessel imaging is a must during acute stroke care, and our ideal test is the CTA, but that comes with a hefty dose of contrast. If your patient has an AKI or CKD, then this is a relative contraindication to obtaining a CTA. That said, if you truly believe the patient in front of you is having a debilitating stroke, just get the CTA. Kidney failure is terrible, but is not nearly as impactful as spending the rest of your life in a nursing home with hemiplegia and aphasia. And finally, please, as I mentioned, please consider bleeding risks for your patients who you might be giving TPA to. So if they're on warfarin, you must get an INR as a level greater than 1.7 as a contraindication to TPA. And then thrombocytopenia is also a relevant contraindication that you would probably look for in a patient you suspect of. All right, let's take a breather. If you're already feeling exhausted from studying, don't worry, my dog Will is in the same boat. Take a second, gather your thoughts, and then we'll keep going. So as the history, physical, and labs that we just discussed are being obtained, the patient should be rushed to the CT scanner. A non-cont head CT is always the first test ordered with a suspicion of stroke, as it's quick and non-invasive and tells us a lot. Most importantly, it will rule out intracranial bleeds, such as this left basal ganglia ICH in this picture. However, the CT is also really good at ruling in early ischemic stroke. I'll discuss this more in the neuroradiology lecture, but you'll see certain signs such as a loss of gray right junction, or sulcal effacement, or a hyperdense vessel sign. Next, as I mentioned, vessel imaging, and specifically a CTA, is imperative in stroke management. While you can consider omitting this in cases where you have a low suspicion of stroke and in patients with CKD, it's really an important test for two reasons. For one, it allows us to visualize if an active thrombus is sitting in the vessel, which we can go after with thrombectomy, and it also is very helpful in the post-stroke workup when determining etiology. So these are the two imaging tests ordered in pretty much every acute stroke workup, but we do have a couple other options that we use in certain situations. One of these orders is the CT perfusion scan, or the CTP. CTP is a scan ordered to evaluate if a patient is a good candidate for clot retrieval via thrombectomy. I'll discuss indications for thrombectomy in the second half of this lecture, but if we think a patient is a good candidate for intervention, we'll usually obtain a CT perfusion to confirm. The CT perfusion is a revolutionary test as it allows us to determine how much of the tissue in the brain is already completely infarcted, which is known as the stroke's core, and how much of it is still salvageable territory, which is known as the penumbra. This is really important because it allows us to predict how successful we'll be if we're able to pull the clot out of the brain. So let's take this picture here on the right. While the person does have a decent sized core, which you can see here in red, it's quite small compared to their penumbra, which is in green, and so the patient does have a lot of salvageable tissue. When you look at the post-stroke MRI done after a thrombectomy, you can see the white area, which represents infarcted tissue, very closely lines up with the core, while we were able to spare nearly the entire penumbra. So it's pretty neat technology. Next is the MRI, which of course is a favorite test for many neurologists. MRI can tell you so much about a brain, and is actually very good about demonstrating acute stroke. It'll appear white on DWI. If what I just said doesn't make sense, just watch the neuroradiology lectures where I talk more about DWI and MRI sequencing. That said, MRI, the biggest reason we don't use it in acute stroke is time. The CT scan can be done in seconds, while the MRI takes several minutes. As we know, time is brain, and time is brain in the world of stroke, and even just a few precious minutes delayed are really crucial. That said, it's really important for you to know one indication for MRI, which we do use in the acute stroke setting. There's a recent study that was published in 2018 called the Workup stroke trial, which I hyperlinked above, and this demonstrates that MRI can be used in patients with unknown last known normal time, such as patients who woke up with a stroke symptoms. This is done by performing a rapid MRI with only two sequences, so DWI and T2 flare. And as I said, DWI will become white in acute stroke almost immediately, while T2 flare will take about 5 or 6 hours to turn white. Thus, if you see an MRI with bright on or an MRI that's bright on DWI but has no signal changes on flare, you can assume that you're within the first few hours of stroke, despite not even knowing the last known normal. So this concept is becoming a lot more common, and you'll likely see us get on a couple patients here. So that's it. That's all the workup that is performed during a code stroke. After that, it's the neurologist's job to quickly synthesize that information and make a decision of whether or not to treat. So let's quickly review. During a code stroke, you want to gather a quick history, including most importantly the time of last known normal, as well as things like associated symptoms or TPA contraindications. You also want to get an NIHSS stroke scale and other pertinent quick exam. And while you're doing this, staff should be obtaining vital signs and some labs, most important of which is glucose. All stroke patients will get a non-cont head CT, and most will get a CTA. And then finally, under special circumstances, you order a CTP for thrombectomy candidates or an MRI for wake-up strokes. And that's it. That's the management of a code stroke for non-neurologists. In the next lecture, we'll talk about certain interventions we use for stroke, as well as how to manage these patients in the period immediately following. See you then.